have in this meeting is going to be live on CTN. It's going to be live streamed on YouTube as well, and it's being recorded. So with that, good morning. Our conversation today is a very important conversation. Obviously, I have a bias. I believe this conversation is going to lead to saving lives of people and citizens of our state. This is about overdose prevention centers. I will first yield to my esteemed co-chair, Representative Steinberg, for some comments, and then I'll continue with my comments.
Thank you, Senator, and good to see you again. Let me start by saying, for those who are watching the proceedings at home, yes, this is the legislature doing its work, and we're not even in session. And it's important for everybody to realize that during the periods of time where we're not passing laws, we're trying to get better informed ourselves and help inform others. Today's subject is one which affects so many people, so many families across the state of Connecticut. Our ongoing opioid epidemic, which certainly preceded anything having to do with COVID and remains as much of a scourge to our communities as it was before. We struggle to figure ways to bend the curve of opioid deaths and bad outcomes. And we are very open-minded as to any means by which we can mitigate the impacts. The state has made some strides. We, every year, I think going back 6, 7, 8 years now, have passed legislation that attempts to deal with the opioid crisis. But there's always more we need to do, and there's always more we need to know about. And I'm hopeful today we will pick up some good additional constructive insights that we can use in the coming session. Thank you, Senator.
Thank you so much, Representative Steinberg. So I wanted to start by making a few statements to put things in perspective. In 2015, we had 728 of citizens of our state die. These were from unintentional drug overdoses. This number had increased to 1,526 in 2021. And this has been the highest increase that we have seen in the last many years. Almost every year, we are seeing an increase in the number of deaths of our citizens. In 2022, as of right now, according to the official numbers, we have 519 people who have died. These are individuals who are our neighbors, friends, families, individuals whose lives could have been complete and full, and then we unfortunately lost these individuals. I know a public health committee under the leadership of Representative Steinberg and all the other members of public health committee, every single year we have been trying to work on ways to address this, and then we have been trying to work as much as possible in areas of opportunity, and we have been successful. But I also wanted to thank our DMIS, DPH, DSS, Attorney General's office, Governor's office, everyone who has literally worked hard with all hands on deck to try and prevent these deaths. And then this is part of the conversation. Is there more that we can do? Are there areas of opportunity, and are there legislative opportunities that we can look at? And as I mentioned, the 2021 was the deadliest year on record for the state of Connecticut for the unintentional drug overdose. And most of these drug overdoses were related to fentanyl and its analogs, which is the commonest substances that are being used at times, which are resulting in some of these deaths. We know that if we provide timely Narcan, naloxone, and oxygen to individuals, we can protect their lives, and then we can avert some of these deaths. And I think that's part of our conversation today, because other parts of the world have really improved with respect to their strategies to address this. For example, Europe, Canada has been working on this for some time. But as we are looking at this situation in the United States, November 30th, 2021, New York City had implemented the first in the country overdose prevention center, which is On Point NYC. And today we will be able to hear a little bit about the On Point NYC experience directly from the executive director of On Point, Sam Rivera, and I will introduce Sam shortly. And then importantly, the first 2 months of the results and experience has already been published in JAMA on the 15th of July. And that gives us quite a bit of an insight and helps us realize that this does work. there are ways of saving lives. There is an opportunity to make a difference. I heard first about the work Sam and the entire team with On Point was doing with an event that was organized by Roots Center for Advanced Recovery with Steven Zuckerman, who's here also, and along with Dr. Podolsky, who's a psychiatrist and chief medical officer for Roots Center for Advanced Recovery. And along with them, we have a number of our stakeholders here, which includes our commissioner for DEMIS, Commissioner Navarrete, along with Mary Kate Mason. We have Department of Public Health representatives with the team with Commissioner Jutani. And Commissioner Jutani is on another important meeting with the governor, but will be joining us shortly. We have representatives from the Department of Social Services with Bill Halsey and Fatmata Williams. And I just mentioned about the Root Center for Advanced Recovery being part of the group. And as stakeholders, we have municipal members and partners, with the city of Hartford being representative, also with the city of New Haven being representative as well in our conversation today. And during the course of this discussion, you will realize why we need to have some of our municipal partners in this effort, in this conversation. Moving forward, I wanted to introduce Sam Rivera. The hope we have is that Sam is going to share his experience. And once we have an opportunity to learn about On Point's experience as the first US-based center which is looking at overdose preventions, we will subsequently be able to have more discussions. We will have a panel and group that is going to ask some of the questions. We will start as chairs of the committee, acting chair and the chair of the committee, and then we will move toward further discussions about with the rest of the group. So Sam Rivera has been, for over 29 years, has been working with the progressive experience in social services. His primary focus of expertise lies in criminal justice and reentry, also with HIV and AIDS and harm reduction, addiction recovery, and mental health. He's currently serving as the executive director of New York's Harm Reduction Educators and Washington Heights Corner Project, two emerging harm reduction organizations that provide services to active drug users and sex workers in northern Manhattan and South Bronx, many of whom are low income or homeless, as well as people of color and LGBTQ community. He brings to this role his several decades of cutting edge service provision experience and a commitment to social justice. He has dedicated his professional career to ameliorating the harms associated with the war on drugs, racism, sexism, structural inequality, and mass incarceration. Sam's commitment is to continue his work to end systemic as well as systematic barriers to populations that are most vulnerable. And I've had the opportunity to hear directly from Sam some of the work he's doing, and he's doing some amazing work and comes from very deep feelings of making a difference, and I can tell you he's making a difference with that. Sam, please go ahead, and we are looking forward to learning from you firsthand. Welcome and thank you.
Wow, thank you so much. It's really a pleasure to be here. At first, I want to acknowledge the fact that you guys aren't in session and you're having this amazing gathering to discuss this important issue. So I truly appreciate that. And I'm speaking for those who are out there still struggling and using drugs and trying to stay alive. So I really appreciate that deeply. And I know that those users and their families appreciate it as well. So yeah, it's been a pretty amazing journey since November. Actually, before we opened, like right before we opened, the journey has been an interesting one and a beautiful one, to get people in power to know that while something sounds so challenging, while something sounds so out there and different, that it's a health intervention that saves lives. And I often tell people that if I wasn't doing this work, I would probably question it myself because of what it sounds like. And what I've learned since we've opened on November 30th is that everyone who's questioned it but visited has changed their mind. Everyone who's walked in that room and saw what we're doing, the love we're showing, folks who are in deep pain, who are in the toughest time in their lives, have changed their minds. So yeah, it's a blessing to be here. It's a blessing to be the head of the organization that's doing it. And I say the head of the organization because I'm not in that room doing it. I mean, I go in the room often and I support as much as possible, but I'm not in that room like my amazing staff who just love our people and have kept hundreds of people alive in just this short time, who have overdosed in our presence, who otherwise would have used in the street and would have likely died, especially with everything that's happening with fentanyl. Every drug we test has fentanyl. And that's where the deep danger comes in our work. But I want to try to keep in some order. I'm also in LA, so I'm a little tired. I've been traveling like crazy. So bear with me. Yeah, so, the process, and I'll go from the beginning, Kaylin C., our Senior Director of Programs, wouldn't stop talking about us opening an OPC, believing we would. And I appreciated that because I work the same way. I believe I believe in something and we go ahead and make it happen. And we continue to create and grow the organization with a plan to open an OPC, 2 OPCs one day. And then the time came and we were talking to the health department. We were selected as the organization who was ready. And we were ready because we intentionally prepared ourselves, similar to what Rouge is doing. And I'm telling you, I've been traveling all over the place, and you in Connecticut are blessed to have an organization like Rouge and the leadership that Steven Zuckerman brings to the table. I had an opportunity to present and meet some of his folks, and they're obviously the right organization to move into this next level of saving lives and keeping people with us until they're ready to stop using. So we had these conversations with the mayor's office and the health department, New York City Health Department, and it's truly a partnership. We didn't do this on our own. We did a lot of work with them, a lot of very, very long and late meetings. And we got to a point where we knew it was going to happen. And it was important for us to do this in sort of a quiet way for a variety of reasons, because we needed to prepare how we're going to talk to the community about it. Because when you hear it, it sounds, it could be very challenging. But that process went through, and we continued to talk and negotiate. And the toughest part, and I'll get into it a little bit as well, is we were clear that we couldn't receive funding for the actual operations of the space. And that was the biggest challenge, because we didn't have much money in the bank, which means we have to use unrestricted funds. We can't use any federal, state, or city dollars to pay for these services. So we had to really raise a lot of money as fast as possible, and blessed with a team who really made that happen, led by Jill Paklemba. So we had a couple of things going on at the same time, the conversations with the city and the mayor's office, the preparation for the program, which was led by Kaylin C., the fundraising, which was led by Jill Paklemba, the operations led by Brittany Vargas Estrella. All of these folks playing a role to making sure this happens. And then the community and people, we knew people would have a hard time with it. And it was important for us to prepare for that. What I told the community is that we responded to their request, and they didn't understand, and they actually got a little upset. But I said, you requested, you didn't want people using drugs in the street in your community. You didn't want people dying in bathrooms in restaurants and places in your community, or public parks, or in front of children's schools. You didn't want paraphernalia all over your community. And we agree. And what we're willing to do. And at first we used to say crazy, and I now say courageous. We're courageous enough to take all of that and bring it indoors to our space. You don't have to see it. You don't have to participate in it. We will bring it indoors to our space. And we will have an impact that so far has been truly immeasurable. So that process went on. We also partnered with the NYPD, the 2 precincts in the 2 locations we're in. And that was pretty amazing as well, because they got it. You know, initially they had a hard time as well. And we thank them, and I thank them now. I thank them every day, because they are partners in this process. They are helping us get to this place. They're keeping people alive as well. The police department saw the impact immediately. They came to us and asked us to create cards that they can hand to people who they used to arrest. So they can go to them and say, here's a card, go to On Point. They're up the block, go in there and get some treatment. Go in there and get a meal, get some coffee, watch television, you know, meet with a case manager, meet with a medical provider, receive acupuncture and acupressure and massage therapy. Go in there and be treated like a human. And that partnership has saved many, many lives in this process. So I'm not sure how much time I have. So I want to, and I'm hoping there's going to be an opportunity for questions and answers, because I can probably go on forever, as the folks at Root know. So a couple of really important things. The landlords matter. If you own the building, even better. But we have 2 amazing landlords who understand that they are playing a role in keeping our people alive. They are heroes in this work. They are stepping up in a way I've never seen a landlord do. In fact, what we've seen in the past are landlords turn their backs on organizations like ours and walk away and leave them out there. In fact, leave them homeless, which is something we experienced for almost 5 years ago. 2 landlords who stepped up and said, no, people need to stay alive. They can receive much more rent than we're able to afford, but they're partners, and they stepped in and continue to be there and support us. And that was truly a blessing. During that time, I also thought quickly, and we worked closely to create we have 2 sites, to create 2 30-year leasehold condos, which give us much more power. But because of our relationship with the landlords, we didn't need that power. So that's truly been a blessing as well. I'll briefly talk about funding. Funding, we have been able to raise over $800,000, which has really been amazing. I would list the foundations who have stepped up and other folks, but we're putting out a press release some point this week. I think by tonight or tomorrow, I hope. That will break all that down. So I don't want to get ahead of them and put it out there, but we are truly grateful to individuals who have stepped up, to the many, many calls and emails and tweets, et cetera, we've received from folks who have lost people, who could only say they wish we had a booth for their child, their nephew, their loved one, before they pass, because we know people do not have to die. They don't. We're proving it. We've had almost 1,500 unique individuals only since, let's call it December 1st. Only 1,500 unique individuals who have utilized the space almost 28,000 times. And that's something to think about as well. And you know, the good doctor you have there talks about it in a way that's so beautiful, understanding that today when you're using drugs, you're using fentanyl. And most times if you're using fentanyl, you need to speedball because you need to keep up as well, right? You have this balance you have to create if you're out there using drugs. So of all those folks, we've had 380 overdose interventions in those rooms, where people started to go into an overdose and our staff responded and kept them with us and kept them alive. Our staff are trained to respond at the level of an RN. Our staff are committed and connected to our people. Kaylin Sia says the least most exciting thing that happens in the room is the drug use. What's beautiful about the room is the community. I'll give you a quick look. When you walk into the organization, oftentimes people think when you open the door, they're just a bunch of people using drugs openly in this space. No, you walk into a drop-in center where people are welcomed and relaxing in an environment and being loved on and being supported. If you're interested in using the OPC, you say that, you meet with someone, you do if you've been there before, we update information on you, and we ask you vital and very important questions. What are you using? How much? Did you intentionally buy fentanyl? Very important question. If you weren't here, where would you use? That's an impact on the community. If someone says, if you guys weren't open, I would be down on the corner at the restaurant using the bathroom, that's important to capture. So we're capturing all that information. At that point, they wait for an opportunity to enter the room, and they enter this locked room, which is separate within the organization, but separate from the larger space. They get in there, and depending on what they're going to use that day, they walk in, they wash their hands, they meet with the staff member who goes over everything they shared, and then they get their paraphernalia and use. And they're monitored throughout that time. If we see an overdose going to start, we respond immediately. I think the biggest, most shocking thing for people about our responses is Narcan is the savior, right? But we've only used Narcan 20% of the time. And we haven't used one dose of nasal Narcan because for a number of reasons. You don't need to if you're there early enough in the overdose. We use intramuscular Narcan, which is 1/10 of the amount used in nasal Narcan. Before we even use it, we go to agitation. We're calling in the individual's name. We're moving their bodies around. We're checking their oxygen. We're checking their blood pressure. And we use oxygen almost just about every time. And that's part of the process to making sure they stay alive. And so in the room, we're watching a decline in drug use because of the community that's happened in the room. They're relating to the staff. They become a part of the community. I was thanking, I probably won't mention the names this time, but I was thanking an actor who did something during an award show for a long time because that conversation literally had people using less drugs because if someone walked in and said, I want to use 2 bags today, and they used 1, but they were in the middle of this debate on whether he should have smacked the guy or not, they didn't use the second bag because they wanted to be present and give their opinion. People who use oftentimes use alone in hiding. Women who use alone and are scared more than ever because oftentimes they're violated. They're protected in our space. They're a part of a community. They can sit there and start to see themselves differently. When we first opened, all our booths have these big mirrors right in front of you with a lot of lighting. People don't want to look at themselves. We're watching this months later. People looking at themselves, people feeling better about themselves, people understanding that they're using drugs to self-medicate pain and traumatic experiences. They're not bad people. They're people in pain who are trying to come out of it. I'm sure many of you, if not all of you, know people who use drugs or drank to a point where they weren't able to function in their best way, and now know them in a different way. I know hundreds. Some of the most amazing, powerful, beautiful people I know were homeless, street workers, suffered pain, and are living a life because harm reduction organizations and other organizations like Root and people who love on people when they can't love on themselves keep them alive. As a Native American person, as an indigenous person, this is part of what we do. We are the medicine. And it's important for folks in your position and your power who are there to represent us to try hard to step back from what it sounds like, from what people will tell you in their opinions, but really look at the facts in the outcomes we've had in this short time. The facts that we're working with humans, and it's not a one pill magic. There's not one thing that just saves people. In healthcare, you have to be fluid. In healthcare, it is, I grew up with a mom who was a nurse for 40 years. And I would ask her as a kid, why do you keep, she worked in the emergency room for a long time. And I would say, why do you keep serving that person? He's here all the time. He doesn't care about himself. And she goes, my job is to care for him until he's ready to care about himself. And I've carried that throughout my career. So I thank my mom every day for blessing me with those lessons. So, and I get to bring my mom's message to those rooms and watch people stay alive because other people care about them when they're at their deepest, darkest times. So we know this works. we know that I'll take one more thing real quick. It's important for you guys for sure. In New York City, and this is a rough number, people are telling me I'm giving a low number. We're estimating that it's about $30,000 when the city responds to an overdose. In New York City, when there's an overdose, they send an ambulance with a number of staff members, medical staff. They send police. They spend time with the individual. They take them to the emergency room. If they stay, the numbers go through the roof. If they die, unfortunately, that also costs the city and that jurisdiction a lot of money. But if we use the $30,000 and we look at 380 overdose interventions, we've called the ambulance 5 times, only 5 times. Of those 5 times were had nothing to do with the overdose. It had to do with other mitigating factors, with other health conditions the staff were concerned about. Of those 5 calls, only 2 left in the ambulance. The other 3 were seen by the medical staff and found to be healthy enough to stay with us. So if you do the math and you just do, 375 times 30,000, it's something, I think it's over $11 million. So that's another way to look at this. If you don't care about users, if you just think if you have your negative opinions about them, what we know is there are other impacts that help community. And the financial one is a big one. And it's one we can't avoid or we shouldn't avoid. We should look at it in that way and honor it as well. I think I'm gonna stop there unless I missed anything. And I'm not sure if we're gonna have questions, but again, I'm truly grateful to be here. I'm passionate about what we do and blessed to be able to do this. And thanks again for having On Point.
Thank you so much, Sam.
Okay.
Thank you for your comments. And I think we'll have a lot of questions as we move forward. I'm going to try and divide the conversation into 2 broad categories. The first category is why, and the second category is how. The why, in my mind, is quite simple. Your published data for the 2 months is very clear. But now that you mention about the 7 months data from On Point, there are 28,000 instances of use of drugs and 0 deaths, 5 ambulance calls, again, happening in an environment where the risk of infectious disease is decreased. And also those individuals have an opportunity to look at other options in life potentially going forward. So, and this is also your data is not a whole lot different than what we have seen in Europe and in parts of Canada. So, and now the NIH and CDC is also talking about the value of the overdose protection centers and some of this opportunity that we can look at. So I think that part is very clear to me of why it is a reasonable thing. It's a very pragmatic harm reduction strategy, which is going to save lives. I think the how is where we may need a little bit more help, because there is a mindset change. There are people who are going to say that, well, is it going to increase the use of drugs? Is this going to cause people to make it more socially acceptable in the community? And then the next part is going to be, if the funding is provided, what is the source of funding, when now we have enough data to say that we can have federal or state or town municipal funding to be part of it. So I'm just going to open this because there are some areas that you can fit, and then I'll move to my co-chair on the questions.
Yeah. So I'm sorry, did you want me to respond?
Please.
Okay, sure. Thank you so much for breaking it out the way you did. That's actually perfect. I need to steal that. Yeah, so there isn't an increase in drug use. There just isn't. We are in an area and in 2 neighborhoods for a reason. It's where the drug use exists at some of the highest rates in the city. We need more. So we're not seeing an increase at all. We don't see an increase of traffic in front of our building. We don't see all of the things that, and again, I respect it. I really do. I respect that thinking. It's logical, but it's just not factual. It's not happening. I want to add two things. Funding. In order to get funded, we need the president who proudly talks about creating the crack house statute to repeal the crack house statute. It's in the way. It's causing deaths throughout this country, and it's unnecessary. And I'm looking forward to the day he does it, because Rahul Gupta, the head of ONDCP, just put out a statement. He's getting it. We're getting closer. And I'm really looking forward to that happening. I also want to say one thing about community impact that I forgot to mention. In our Washington Heights location, we're across the street from a park, a beautiful park. There's been almost shut down for many years because of drug use and other reasons. In that park, we partner with the Parks Department, and we collect syringes and we clean the park and we go through and find homeless folks and work with them. Before November, the park averaged 13,000 syringes collected monthly, 13,000. Since we've opened, and they called us freaking out. They called us like, what is going on? Did you hire more people? Are you coming into the park more often? That 13,000 became 1,000. And my team and I cried in such pride, because I watched a park that was almost closed to kids on the swings now. And every time I go to my office in Washington Heights, I stop to look at that park and watch kids in the swings. And one of my goals before I leave this job is to see the entire park open, because of the impact we're having. So I wanted to add those two things.
I want to thank you for this presentation. You heard how we opened today. We were talking about the numbers, and the numbers can, I think, distract us from the reality of individuals. And I was struck by a couple of the words that you focused on. The first being pain, and that's the point of encounter for so many people who have legitimate, serious pain issues and then find themselves caught up in opioids and other medications that change their lives. And I think that's important for us to remember, that it's not just about statistics. Secondly, you brought up the word caring. And I think what we really appreciate here is we've gotten past the numbers and you've given us an explanation, sort of real world feet on the street about what happens with individuals. And I think the key takeaway from that is that everybody has their own path, their own trajectory. The stories are not absolutely synonymous. And the work that you've been doing gives us hope, encouragement, that there is a path for more and more people if we can reach more and more people in a timely manner. Having said how much I appreciate your giving us that insight, I want to go back to numbers for a minute. Connecticut is blessed, perhaps for the first time in my decade plus experience in the legislature, with some funds. Thanks to the work of our Attorney General, we have more money available to address this problem than we've had in the past. And DEMAS and DPH have done everything they can to support programs out in the field to mitigate the problem. But we're actually in a position to do more, in theory, if we apply those funds appropriately. And that's why this committee is demanded to remain involved in the process, whether with the governor's office or the agencies, and how these funds ultimately need to be allocated appropriately. So my question for you is, we've heard the qualitative anecdotal stories that you describe, how things are different. Do we have the data to support which programs are successful? Because those are the ones we want to both reward and continue to fund and allow to expand, but also potentially scale up across the state such that more and more people can be helped in the manner that you described. So my question for you is, do we have good data? Do we have an ability to discriminate between programs? And what would it take for us to get that?
So that question is for me, correct?
If you're willing to answer it, you're the guy.
Yeah, I believe you do, and I think some of your local folks should chime in. But I believe you do. I believe specifically for overdose prevention centers, the data is real. and the data exists. And you mentioned, and thank you so much for your kind words. I mean, thank you for your insight and your vision. We need more folks who can see this journey the way you're seeing it. But truly, the data is real. The data exists. We have lots of information that most folks who come out of treatment relapse, and we should be prepared for that. It doesn't mean failure. I think one of the things that treatment providers have done to themselves, and it's not really their fault, it's sort of these structures that keep trying to make people land what's considered success. And so I believe in my 30 years of doing this work that treatment providers have had to create these processes where while the person's with them, they're really monitoring everything they're doing and how well they're doing. But when they leave, they have to sort of disconnect because they don't have the same interaction they had before, unless they have aftercare. So that's where it gets very challenging. And I don't blame the treatment providers. I blame the funders who've created these processes and have, created a place where if someone uses again, there's this major failure. And I often have to use examples of diets. When someone starts a diet and they start on Monday, they do well till Wednesday or Thursday. And if they relapse, they eat everything they want till next Monday and start again. And the difference is we don't judge them, and well, sometimes we do, but we don't attack them in a way that they're attacked. And they also don't lose housing and all, and jobs and everything else. So the data is there, the data is real. People will stop using, they will. If anyone believes that they themselves get someone to stop using, they really need to look at that. What we do is offer opportunities. What I see Root and other great organizations do is show people how their life could be when they're ready to stop. And then when they stop, you watch that happen. But it's not us. It's not the provider who makes it happen. We give the opportunities, the options, and the participant decides when it's time for them. And what we need to do is exist until they're ready.
Thank you for that. I think the other key point you just emphasized is that it is a journey. It is an odyssey, frankly, for many people. And one or two or even three encounters don't describe the ongoing relationship that providers need to have with people who are in this kind of trouble. And if we're going to really help them get through to the other side, it's a lifelong concern, addiction most broadly. Thank you for this. I'm hoping maybe I can get a little bit more amplification from maybe our agency folks when we get to them. Thank you, Senator.
Thank you so much, Representative Steinberg. One of our ranking members, Senator Summers, had a question, but she lost her connection, so I just texted her. She may join in a little bit. I have Mr. Steven Zuckerman, who is CEO for Root Center. I have a question from him or a comment, but after that, I would love for our commissioners who are here for DPH as well as for DMIS to weigh in as well after Mr. Zuckerman. So Steven, go ahead.
Well, yeah, I just want to thank Sam. So for those who came to our community forum last month, Sam is enthralling. So listening to him to speak makes you want to go and do everything he talks about. But one question I thought would be helpful for the group that Sam didn't cover, I know he and I talked about at the forum, is what is their current oversight and regulatory bodies with respect to city and state? How are they, what are the regulations and how are you monitored? Because I think it's important for our folks to be able to understand that process as it relates to the OPCs in New York City currently. Who regulates you, if anyone?
We regulate ourselves right now. There isn't a regulating body. The blessing for us is we're very strict on ourselves. We really, so I'll give you a couple of very quick things. One is every person, I've had many people tweet at me and yell at me and say, just send them to treatment. This is not a bash on treatment or detox. 100% of our participants, 100%, every person I mentioned has been in detox and treatment multiple times. And we want to get them to the next time. We want to keep them here for the next time because it is a journey. It is this process that's lifelong. So that's one thing. Yeah, we're not regulated. But we've created our own regulations sort of to hold ourselves accountable. You know, Dr. Anwar talked about Europe. Europe, you know, many of all of those organizations in Europe have really paved the way for us. We know that in 35 years, not one person, not one, has died of an overdose in an OPC, not one. And it's important for us to continue that. It's important for the organization, not if, but when you open in Connecticut, when you open a few of them in Connecticut, that they continue to do that. So we've created an intense policy and procedures and lots of protocols internally for how we respond. One thing I'll add quickly is, in order to work in the OPC, you have to, one, opt in. You have to say you want to work. So staff are not mandated to work in the OPC. They say they want to work, and some of them have been with us for years. They still have to go through an additional training. Then they go in the room, and they're not allowed to respond to an overdose, even though they have many outside of the room, for a while, because the overdose in the room is very different. It happens, we're responding immediately. So they have to retrain themselves. So they're not, you know, so the process for them to even start responding to overdose takes a long time as well. And those are, you know, thank you, Stephen. Those are the sort of regulations we put on ourselves. I will say, when we met with folks on the federal level and folks, our health commissioner and other people, we said we want to be involved in the creation of the regulations, because we, you know, and not in a bragging way, we have it. We have it. We are the medicine. We have it. It's working. And we want to make sure that anyone who opens anywhere spend some time with us, and we spend some time with them, so we can continue this successful life-saving intervention.
Thanks, Sam.
Stephen, you had another point or?
Well, I want to thank Sam for that. I guess for the folks that don't know about the Root Center for Advanced Recovery, so we serve approximately 6,000 patients a day with opioid dependence. So that's not a week, that's not a month, it's a day. Certainly the largest provider of opioid dependence treatment in Connecticut, and probably one of the largest in the country. We're very excited for the opportunity to be able to pursue this. Obviously, Sam talked about funding. His funding currently now is a result of fundraising. We have to think about how this can be reimbursed. We know there's a lot of settlement money coming to the state as a result of the great work of the Attorney General, which we already spoke about. Can monies be directed towards that for funding of this? I certainly have had some conversations with our board of directors. They are very excited about the prospect of doing something like this, again, for our 6,000 patients a day. So we would certainly be willing to take that on, and even speaking to them about other monetary uses that we have set aside for strategic goals, to be able to consider using those monies until funding comes to pass in another way. I think the largest issue beyond funding, and Sam talked a little bit about this with some great landlords, is real estate. Even if we bought our own site to be able to do this, I've seen just in the past few years in attempting to open up a methadone clinic in Middletown, which has been a battle. P.L.Z., Planning and Zoning Commission, will have a hard time approving something like this in one of their towns. So even if money is there, based upon the angst that we've had in trying to open up even just a methadone treatment center, this is sort of well beyond, in many people's minds, than opening up a methadone treatment center. So that's something we have to talk about. And how do we get past that? How do we get beyond the fact that there's not going to be a town in the state that's PL&Z is going to let us come in to do the work? So that's going to be a major discussion that has to ensue even after funding happens. Thank you.
Thank you. This is helpful. Before Sam responds, I wanted to see if we can get our commissioners to weigh in as well. And wanted to start with the DMIS Commissioner, Commissioner Navarrete, if you want to weigh in, and if you had any questions for Sam, but also with what we are hearing, and how would DMIS look at this, and what kind of partnerships and strategies we can come up with, and what can the legislative process be useful for?
Well, it's an important conversation. I agree that we are in a crisis. We've been in a crisis for some time now. So any and all strategies, our ears are open. We're glad to be at the table, glad to have people with different points of view, and acknowledge basically what Stephen just acknowledged and others before him, that there are a lot of hurdles. Some can be more easily overcome than others. So glad to be at the table to continue the discussion with DPH and our other state agencies in the governor's office.
Thank you, Commissioner. Commissioner Jitani?
Yes, thank you, Senator Anwar, and thank you for this opportunity to hear this presentation and discussion directly. Sam, it was wonderful to hear your experience. I really appreciated being able to hear directly on the impact this is having that you've seen so far. As Commissioner Navarrete said, we know that we are in another crisis, another epidemic that's been lasting long before COVID, monkeypox, et cetera, that we are dealing with right now. And as Commissioner Navarrete said, I am all ears for any and all options in terms of harm reduction that we can entertain in the state, and we'll look forward to working with our legislators and others on exploring all options that we can look at going forward. I did have one question where I lacked some clarity. Sam, if you wouldn't mind clarifying, when you were talking about Narcan administration, I thought I understood in your follow-up that your staff does not actually do that. Did I misunderstand that? Or could you clarify what they can do, what they can't do exactly in your facility?
Yeah, staff actually, no, thank you for that question. The staff actually respond with intramuscular. If we go to a point where we use Narcan, it's an intramuscular shot, not the 4 milligram nasal, which people use in the street, and you should, don't stop using it, that you see someone who has an overdose. It is just, and I'll give you a couple of reasons why. One is it's really strong and oftentimes too much. And what it does is the person comes out with withdrawals, very sick, and they also have to stay with us a long time because that overdose can return. When you use intramuscular, it's very different. You're using a tenth of the amount, and basically what we need to do is well, you know this, I'm looking at you, but I'll say for everyone, is remove the opioid from the brain, right? And give oxygen. So we use oxygen, and that's something that harm reductionists who come and visit, people who are good at this, doctors who have visited are like, wow, you guys are using oxygen? We're using so much oxygen, doctor, that we have a machine downstairs in our basement refilling our tanks 24 hours a day. And we use that oxygen at every overdose. And so the blessing there is we don't want to use Narcan if we don't have to, right? Why use medicine in that way if you don't have to? So yeah, so 20% of the time, intramuscular. If you come in the room, you will see the nasal, it's there. We haven't used one yet of the 380 overdose interventions.
Thank you for clarifying that. That makes a lot more sense to me. I couldn't imagine you weren't using Narcan at all, but that makes a lot more sense. If I could ask one other clarifying question, just in terms of location that Stephen mentioned, did you have any challenges with that in terms of finding a location where you could have your facility?
Oh, thank you. You reminded me of something I should have said. This program, in my opinion, must be co-located with other services, must be. So we built this out within our other services. Why? So we've had people at the room, doctor, people at the booth we're using say, I no more, I want to go to detox right now. And the team reacts right away. We get a case manager, we call the detox, the company that provides detox. We get them to show up, pick this person up and go. Sometimes the person at the booth wants case management. They want to see a medical professional. When I first came to this job, I kept hearing about Dr. Lee. I'm like, this guy, Dr. Lee, is pretty amazing. And what I learned is Dr. Lee worked in an emergency room. So all our people were going to emergency room, costing major money and also not appropriate healthcare to get regularly, right? You want to see. So what we've done by having low threshold medical services is introduce our people to how to negotiate and how to have conversations with a medical provider. And one of our biggest successes is watching people who utilize the emergency room as their provider, having a provider, having their own PCP, seeing them regularly, especially because many of our people have other medical conditions, chronic conditions as well. So yeah, it's really important to have that opportunity for our people. And it just has to be co-located so that the other services are there right away. And it also gives people an opportunity to see what their future can look like. Many of our staff, more than 50% of our staff are folks with lived experience. So when they look at them and say, you have no idea what I'm going through, and they share their own story, it's a major tool in the toolbox. It really inspires people to believe that they can be us.
Thank you.
This is the time before I get Stephen in again. I wanted to see if our municipal partners from the city of New Haven, city of Hartford, if they want to weigh in, specifically also looking at it from the future potential, but also the challenges within the cities. If we were to move in that direction, if anybody wants to weigh in, you're welcome to do so right now.
I'd weigh in. I can't find the function to raise my hand, Senator Anwar, so I'll just start. Can you hear me?
Yes, please. Go ahead, Dr.
Good morning. My name is Dr. Mehul Dalal. I oversee community services in the city of New Haven, which is the Health and Human Services Department. Thank you for your presentation, Mr. Rivera. I do have a couple of questions. I think, in New Haven, we're seeing the brunt of this crisis. We had more OD-related deaths last year in 2021 than we had COVID by quite a margin. So we're really seeing this as a public health crisis situation here in New Haven. Along with the deaths, we have increasing public order concerns as well with many folks openly using. So again, as the commissioners mentioned, I'm also all ears in terms of solutions. I had a couple of questions for you, Mr. Rivera. I think one of the issues that might be rate limiting for us is the siting, and I know you touched on some of this, but if you could say a little bit more about the neighborhood engagement, the siting of the site, and whether you needed to either advocate for enabling legislation, either at the state or local level, or overcome some restrictive legislation. If you could speak to those questions, that'd be really helpful. Thank you. Sure.
So the first one around siting, again, something I say is important is you, if possible, you want to open in a location that already exists, where people know where to go, where people know the organization. So we didn't find a new site. It was important for us to stay and build this out in both of our locations. People know us, they knew where to come in, the neighborhood knew we existed. It was very confusing in the beginning for the neighborhood though. There were people saying, we don't want you here. We don't want another treatment program. Not that they didn't want treatment programs, just because the two neighborhoods, the community believes they're oversaturated with treatment programs. So it wasn't about that, it was about too many. So we had to educate folks and tell them who we are and the difference. So again, it was important to open up within a location that already existed and expand the services within those locations. The community folks, it was important to engage them right away when we opened. We invited them in. One of the big things I will say is allow people to come in and walk through and see it for themselves, because even our biggest supporters have no idea what it looks like until they show up, and they're blown away by it. As far as legislation, no, because there isn't any. We didn't have to work through any of that. We got, and I'll be very honest, and this is being recorded, but I'm going to say, part of it was intentional, because something didn't exist either. There wasn't a thing that said you cannot. And I think one of the things that happen is people create these barriers themselves. Because if you look through legislation, does it exist? It really doesn't in many jurisdictions. So really what we needed was the support of the health department, the support of the mayor in our case, the support of the incoming mayor, which has been a blessing. So I always thank former Mayor de Blasio and of course our current mayor, who before coming in, we made sure we had communication with his team, and they supported us and said they would. And then when they came in, they supported us right away. And so it's important to be careful around sort of creating legislation. We've seen that in other jurisdictions. I won't mention, you probably know. And what happens is then you create a situation that slows down or actually prevents the locations from opening. So yeah, it's this is the other side of not having legislation against, is not to create new, but also make sure that you have, and many of you folks are sitting here in this meeting, make sure that you have the support from an understanding from the leadership on the health department side, and any of the other folks who can make decisions based on the function and the success of the program.
Thank you. And I have Kevin Alvarez from and then we'll have Stephen Zuckerman again. So go ahead, Kevin.
Thank you very much, Senator, and thank you for the information you've provided us and all of the incredible work you're doing and the lives that you're saving through that work. I was curious for, if say Connecticut was pursuing this, I think the city of New Haven and the mayor are quite eager to pursue anything that is shown to work and is going to compassionately try to help as many people as possible. So there's the political will there, but if there was both the state and the local government coordinating on this and resources because of our opioid settlement available, are there particular wraparound services that you think would be most important to also invest in, whether it be transportation, mental health counseling? What are those that we should be thinking not just about these centers, but what should be our priorities to pair along with it? So thank you so much.
Wow, you guys are great. Thank you. You make me emotional. Mental health. We have mental health providers, our own, providing mental health services inside the OPC. And again, that's different. It's not radical, it's righteous. It's different. You're not supposed to work with someone who's actively using. That's not true. Work with them when they want to be worked with. So we have providers at the booth while someone is, not actually using, right before, during, sitting with them saying, what's happening for you? What's going on? What do you need? Are you on your medication? Are you taking it? Do you have something, prescribed to you? Where are we? So mental health, yes. Other medical services, and I'm sure you have the same experience in Connecticut. Our folks utilize the ER as their medical provider, which is unhealthy for a variety of reasons, right? So we want our people connected. And thinking future, right? So food, very, very important. We serve 3 meals a day. How did I forget to say that? 3 meals a day. You want also folks to be able to stay engaged when they come in for a long time throughout the day. One of the things we're about to open, is the respite opportunity. What does that mean? So right now, I want to be clear, we're not open 24 hours a day. That's where we're heading. And it pains us every night when we close. It pains us because we know folks are going to use outside and potentially die. And we've had it happen. So we're creating a respite program where, and you'll see this a lot of times with women, which is so painful, where you might find a woman sleeping on a bench during the day because it's safest for her. And that's sad because at least people can see and people are walking around. So we're creating a room where people could come in and take a nice long nap. I also forgot to mention, we have showers available for people. So those, you want that. We wash clothes for people. So someone comes in to utilize the OPC, they drop their clothes off. If they have to wait a little bit, they might take a shower. We provide some underwear and clothing. They have a meal. They spend time. They go in the room to use, and I mentioned this before, and it's hard to capture. That's the hard part. It is anecdotal, but folks use less because they also have other things to do. They're going to use, but then they have a meeting with their case manager. They have a meeting with the medical provider. We provide COVID vaccines. You want to really become a part of the community. We're opening a pharmacy indoors in our location so that one of the things we know, and I'm sure Steve and his team know this, that all of you doctors here, you prescribe, but do they actually go and pick up the prescription? That seems to be a disconnect. Can you imagine our folks be receiving a prescription and walking 30 feet and having it filled right there on site? So yeah, you want as many co-located services for people to stay engaged and for people to really believe that they can live a normal life and watch this process happen. So yeah, I mean, the crucial ones are mental health, food, housing, if you can. We're working towards housing. We definitely connect our folks to housing. Any kind of educational programs, if you can, and that's oftentimes a little later in the process. Because one of the things we also want to watch is if we engage people in many things too early, it could become overwhelming, and that pain shows up again, and the answer to address the pain oftentimes ends up being drug use.
Thank you for that. Mr. Kevin, do you have a follow-up or you're?
No, I just want to say thank you. And it's something that we are in the city of New Haven very eager to try to make sure that works, and so that we can take care of our residents and save a lot of lives. So thank you very much.
And during the course of our conversation today, we will have a plan of action, hopefully. Let's see. Mr. Zuckerman, you're on.
Yeah, it was just one comment based upon what Sam said. I think Sam just put forth something that could be very helpful from the real estate perspective. I know for Root, I'm sure many other organizations in Connecticut, we have many of our sites with a great deal of unfinished space. So this cohabitation with all of the other services, the eclectic array of services that we currently have, to build out at one of our current sites would certainly help with the real estate issue going into a new community, looking for a new location and doing a new build out. So I think that does help that aspect of things tremendously. It doesn't take away the money problem, but it certainly helps with the real estate problem for those organizations that have the ability to look at their current setup at their sites to see if there's opportunities for build out. We certainly have that at our Manchester site, at our New Britain site, and at our Torrington site, just to name 3 out of 10.
Thank you for that. I know our DSS partners have not weighed in yet. If you guys want anybody from DSS who's here, if they want to make a few comments, I'm going to start another group of questions I wanted to quickly talk about.
Thank you so much. This is Bill Halsey from the Department of Social Services. Thanks for the opportunity to comment. Just thank you again for convening this. Sam, thank you so much for agreeing to present. I echo the other commissioners, Commissioner Navarrete, Commissioner Gittani. We are here to listen, to be partners in solutions wherever the Medicaid program can assist. So we are eager participants and partners on this journey. Thank you so much.
Thank you so much. With that, I have Mr. Mark Jenkins, who's the Executive Director of the Connecticut Harm Reduction Alliance, who wants to make a comment as well. Go ahead, Mr. Jenkins.
Thank you. And thank you for you speaking, Sam, and for the Root Center and this work at the Connecticut Harm Reduction Alliance. We are the state's only harm reduction organization by mission, vision, and value, meaning that's all we do. And we operate presently the state's only harm reduction drop-in center at 557 Albany Avenue. And, we partnered with the state actually back in 2019 to do a paper that was going to go, again, prior to COVID, to be used at the National Harm Reduction Conference as a paper on quasi overdose prevention sites. Sam, I appreciate the work you all do out there, and we haven't had an opportunity to meet yet. Many of my associates have spoken with you and been out there, and I look forward to getting out there. Many of your outreach workers I know firsthand. I'm also co-chair of the state's harm reduction action work group, and we're also looking to see how we can move, legislation and things forward in this next session, hopefully, to see this stuff happen. At our site at Albany Avenue just this past year, we saw a number of close to 1,000 unique clients with over 6,000 visits to that site of people actually exchanging paraphernalia agency-wide. We have over 3,450 unique individuals, which we saw for over 24,000 engagements last year, collected over 748,000 syringes, dispensed over 748,000, and collect over 605. Probably the state's largest hand-to-hand dispenser of naloxone, as well as fentanyl test strips, and we are, really glad this is moving forward. There have been a few conversations about it in the past, so to see it take this level of to reach this level here now is gratifying, and I'm glad to see it happen. We seek to work however we can to, because we understand, and Sam, hearing you speak, it just affirms everything that we've done to date in standing up our center and having a treatment on demand model and having those other pieces in place. And then again, location, having them right in the center in a part of the community and providing those other services we found. And again, like you said, loving on people. That's the difference, I think, the huge difference of our services is that, we're right there meeting folk where they are and providing services that have value to them. So thank you, Sam. Thank you, Root Center, for having this. And
Thank you so much. Sam, I had a quick little question. I know many of the people, legislators, officials, part of DPH and maybe DMIS, would like to visit your center. We probably may have to take a bus over to New York. Can you help us coordinate some of this so that we can actually see the facility and get a better hands-on understanding more so if we were to move in that direction? I know our municipal partners, potential partners may be interested in that too.
Yes, definitely. And in fact, Brittany Vargas Estela is on here somewhere. I don't see her, but I think she's posting in the chat now. We would love to have you visit. We will schedule that, especially, we're prioritizing jurisdictions who are moving in that direction. We want you to visit. We will be able to host you immediately. So I'm sure we're putting information in the chat. We would like to happen. I want to say something quickly to Mark. I want to just tell, Terrell and Marilyn, a bunch of people tell me to make sure I said hi to you. A true warrior in the work in Connecticut. We appreciate you. But yeah, please come visit. It's really, I can talk about this. I think I'm going to ask Britt to also add there's a couple of really good pieces. We've been on the news many times, but there are a couple of really good ones you guys might want to watch. There's a piece by the Invisible People. It's a short. I would have used it here if I didn't want to take too much time. It's 12 minutes, around 12, 13 minutes. It gives you a good view into what we're doing, but visiting would be very different. But that would be a good place to start. So I'll ask Britt to share that here as well.
Thank you so much. Okay. Let me have, actually first I will, well, go ahead. We have Anusha Dungana from the city of Hartford. Please go ahead, Anusha.
Hello, Sam, and hello, everyone. This is Anusha Dungana. I'm representing on behalf of city of Hartford. So I just have one quick question. I didn't get it earlier. So this center, do you have like any after hours, weekend hours, or the same kind of facility during weekends or holiday, or like after 5 p.m., 6 p.m. Because in city of Hartford, we do see a lot of Overdose, and as Mark is here, he has some after hours services to their clients. So do you have anything similar to that? Thank you.
Yeah, so we are open in our Harlem site, East Harlem site. We're open Monday through Friday. We were open from 8 a.m. to 9 p.m. No, 9 a.m. to 8 p.m. But I'll give you a quick story what happened just recently and our partnership with the police department. For me to receive, for myself and our senior director, Kaylin C., we received a text from the captain of the local precinct asking us if we're seeing, what are we seeing in Marcus Garvey Park? Something's different. What's going on? This is a captain of the New York City Police Department. Because they found overnight about 5, 6 a.m., they found a couple of folks, one person who died, another one who was in the middle of an overdose. And we have a outreach and public safety team that responds, that goes to various community, I should have mentioned that earlier, that truly impacts the community, because if a person sees one syringe and they call us, we send our team out to get it. But we do cover areas where we know there's traffic and people might be using. So the point of that is we open 9 a.m. to 8 p.m. We got this text and then conversation with the captain of the local precinct. We started to go into this park at 6 a.m. The minute we met with our team and said, we have a situation, because we have a 3-phase plan. We're still in phase 1.5 now. Phase 2 would be to increase from 7 a.m. to 11 p.m. And phase 3 is 24 hours, 2 locations. And it's important. We're getting there. We're getting there slowly. Of course, money matters. And what we know is in order to run both sites 24 hours a day, just the OPCs, it's roughly $3 million. And if you look at budget, that's a drop. That's nothing to save hundreds of lives. We look at 380, for me, becomes 500 if we were open 24 hours a day. Easily. It probably doubles. But yeah, so we're open Monday through Friday in our East Harlem location. Weekends we're closed, and that's painful, but we just can't afford it. And then in our Washington Heights location, we're open Monday through Friday, same hours, but we're open on the weekends in Washington Heights from 9 p.m. to 4 p.m., 9 a.m. to 4 p.m. So we are open in the evening. We are providing meals later in the day, but unfortunately, because of funding or lack of funding, those are our current hours.
Thank you so much. And I have Representative John Michael Parker, who's one of the most passionate advocates I know for addressing the opioid epidemic. So Representative Parker.
Thanks, Dr. Anwar. Thanks for being here with us, Sam. It's great to hear from you. You've spoken a lot about the partnership with the City of New York. And to that point, it's awesome. We have municipal partners here representing Hartford and New Haven. Curious if you want to share anything else about the extent you've had a relationship or need to do work at the state level. I really appreciated your point about not creating legislation that's going to get in the way of you, but have you had to interact with any, whether it was statewide agencies or the legislature in any way? And if not, or you want to share else, just curious if you want to talk about a few other roadblocks you had in dealing with the municipalities. I mean, the way you've told it sounds like you had a lot of support from the mayor's office and other officials. I don't know if it was always that way, if you had to sort of convince them. So if you could talk about what that process was too, I'd appreciate it. Thank you.
Sure. We have a lot of support, lots and lots of support throughout the city and state. And yes, we have many partners in the city council, many partners. We had a bill that didn't go through completely on the state side, but we have folks leading that. It was last minute, right before the end of session, so it didn't go through, but we believe it will. We have the governor who's supporting us, but is in the middle of a race right now, so we're respecting that process. We have an amazing head now of our state OASAS, our state treatment providers, the body that funds treatment throughout the state, and substance abuse services. As you can tell, I have a hard time saying that. I don't agree with the language, but a lot of support, a lot of almost everyone who plays a role, like you guys, have shown up and visited, have supported us publicly. So we know that when we know 100% that now when things get to the table for a vote, we're really confident that it's going to be okay. Because the other thing is, while we're waiting for Biden to make this decision, and I truly believe he will, we're waiting for him to repeal the crack out statute, which will then allow multiple funders to fund us. And we have so many who are ready to fund us, who are trying to be creative about funding us. In the interim, we have to then focus on the state and what can the state do? And we know the state can do something. But again, we're in the middle of a race. It looks like, we want to give them space. It looks like we have to wait till November. But we're excited and truly believe that folks are getting it. Many people kept saying in the beginning, well, we have data from other countries. We don't have it here, but we didn't open here. We were so blessed to have both previous Mayor de Blasio and the current Mayor Adams step up. Mayor Adams, I'll tell you, he gets it. He just looked at it without all of the emotions attached to it. But is this working? Let me talk to doctors. Let me talk to healthcare professionals. Does it work? Legislatively, and those pieces are important. So having folks having meetings like this right now, having opportunities to talk about it, for me is what shifts folks in the right direction to understand. And so I know it's going to head there soon. I'm sure I'll be in DC in the winter a few times talking about this. And I'm looking forward to celebrating the end of the crack-out statute, multiple sites opening throughout the country, and receiving as much support from folks like you guys in these positions of power, who we rely on to guide us and save our communities as needed, especially folks who are in the deep parts of their lives where they're using drugs. And I said many times, there's no war on drugs. There's a war on drug users. I'm from an island I call Borinquen. Many people call Puerto Rico. But I can't bring an avocado from Puerto Rico. But many drugs are entering this country by the second. So the war on drugs, for me, doesn't exist. The war on drug users is very strong. And thanks to folks like you, we're starting to beat it.
Thanks for sharing that.
Next is Representative Jamie Foster, the question.
Thank you so much for being with us here today. As I've listened to you and the other speakers, I've thought a lot about the district that I represent that is quite a bit more rural, but we still face challenges of opioid use being a concern and overdose occurring. How, and this might be asking you to speculate, but how would you imagine a center like yours being proximally located to more rural areas might make a difference? Or do you have any data or examples from your practice about how a center like yours might impact surrounding suburbs or rural communities where opioid use and abuse is still a problem and overdose risk is still high? Thank you.
I truly appreciate your question because I'm born and raised in New York. You might I might have a little bit of an accent. And oftentimes city folks look at city. We don't think about rural areas. And what we know in New York, we have a couple of rural areas that need an OPC now, right now. So it can work. It could definitely work. The other thing I want you to really think about, and I truly appreciate the question because again, it's important, if possible, to open in an already existing location. Because if suddenly, so when people walk into our building, they could be walking in for a variety of things. They're not walking in to use the OPC. Maybe they are, but not necessarily. They might be walking in to receive an acupuncture treatment. They might be walking in to see a medical provider. They might be, so I would suggest the same in a rural area where it's not like, if you create just that, then it's also tough for the participant. It's also tough for the person who needs to go there because then they have to manage that level of pushback from the community, personal embarrassment, etc. So as much as possible, what we've seen around many different places is sometimes in a rural area, they might have it in a hospital. They exist in hospitals throughout the world. So you want to be creative as to where you do it, but you don't want people to have to travel so far. And that was one of the things we had to teach people in New York as well. They were saying, now, because we only have two, one in Harlem and one in Washington Heights, we're going to get people from Brooklyn and people from No, drug users aren't going to buy a drug and then get on a subway or a train or drive all the way to a location to use. If you know drug users, they're going to buy a drug and need to use sort of quickly. So that's usually, that's the process. So you're not getting that. So the concern there is if you have drug users in a rural area and they have to travel to a city, then it's just not likely to work. So you want to be as creative and as fluid as possible when you're opening these sites.
Thank you. Representative Zapkus.
Thank you. And Sam, thank you for doing what you're doing. I mean, unfortunately, a lot of us have been touched in one way or another by this. And it is a crisis, and it has been a crisis for a very long time. So I'm grateful for what you're doing for a lot of people. I just have a couple of questions. Two are clarifying questions. One is and I came in little bits and pieces. You said you are not regulated. You create your own regulations?
Yes, we're not regulated because we're not recognized. It's an intervention that's not recognized locally or nationally. So there's no regulation. Do we know that the health department is working with us closely? If we were doing something that was inappropriate or off, believe me, they would come in and let us know. We talk to the health department almost every day, both the city and state. The state, don't forget, the state funds us to run our SSP, our syringe exchange program. So we are, while we're not regulated specifically in the OPCs, people are watching what we're doing and appreciating what we're doing. We have our policy and procedures just for the OPC is over 100 pages. It's pretty intense. And we didn't create something without influence from already existing OPCs in the world. I mentioned Kaylin C before. Kaylin worked in Vancouver. Kaylin started OPCs in Canada. So she works for us and was really the lead in creating the actual OPCs themselves. Right now, that's something that keeps coming up around regulation. If we, as we move in that direction, we really want to be involved in what that looks like. And one of the things we do, we've had too many organizations call us and say, "Can I have a copy of your policy and procedure?" And I feel like an open, and we tell them no. It's not that simple. You need to invest. You need to visit. You need to make sure you know what you're doing. You need to make sure you're really ready to do this. We're just not going to give out information and put other people's lives at risk. So that's currently where we are.
Okay, thank you. My second question is, I think you answered part of it. And I also thought I heard that you get no money from the federal or state government. Is that correct?
100% correct. We receive nothing. So all of the other programs that are co-located with the OPC, we're funded for those, but we cannot, because of the crack-out statute, we cannot legally be funded by city, state, or federal dollars at this point.
Okay, great, thank you. And I guess my last comment and question to you is, because this is such a crisis and it's getting worse and worse, as you said just a minute ago, fentanyl's coming over the border in massive. I mean, I heard a statistic, there's so much fentanyl coming over, it could kill, each American twice. Just horrific. Yeah. And I am always thinking we have to work on what's happening now, but get to the root of the problem. And my question to you is, How do we do that? What is that? I know that's a big question, and if we all had the answers, we would fix it instantly. But it a lot of times, and I'm not saying you're doing this, but as I have worked in Hartford, I see that we always work on the surface, and we really need to get down to the root of the problem. And so I guess I ask you, what if you've been in it for so long and are working with all of these folks, what is the root of the problem? What is the cause? I know everybody comes from different backgrounds and bad places and different times in your life and all those things, but what is it?
Yeah, for me, the root is, this is why I say there's not a war on drugs, because if there was we know where drugs come from. The world knows where drugs come from. And you watch a television show or a news footage of them shutting down an opioid, place in another country, and look at what we've done. But there are millions of those. There are many, many, many more of those. And you're right, we're working at the surface, right? The root is here. If I can work from the root, which is what we're doing with the individual when they come in, it's like, what's the root cause for you using? Let's get way down there and figure out what that is. And we find abuse and sexual abuse, physical abuse, and mental health, illness, etc. It's the same thing with this influx of fentanyl and everything else. What you find instead is, let's run into the neighborhood and arrest all those people who are selling it. It doesn't stop it from coming in, right? I mean, if you look at it logically, if you can't get drugs into a country, then people can't sell them. If you can't, right? So the root is way away from us. And it's not the border. It goes deeper than that, really, really deeper than that. What we see as Black and brown people and poor white people is, in a way, the country allowing drugs to come in and then addressing those who sell the drugs and use the drugs. And that's why I keep saying there's a war on drug users. It's not addressing where it's coming from. Right? If you have an electrical problem, if you have a plumbing issue in your house, you don't keep working with the sink. One of the first things you do is turn the water off from entering the house, right? you have to turn the main valve off, and then you start fixing everything else. And it sounds simple, but it really is almost that simple. It's not simple to go out to these other countries and figure it out, but it's a system. It's a system that's been functioning for many, many years, where it keeps the criminal justice system going, it keeps policing going, it keeps a number of things going in these communities. And it's just this constant rotation where we went from heroin and crack and meth and fentanyl. This is what we keep doing. And so what's next, right? What's next? And it's a shame. It's a shame. And that's why I don't accept that there's a war on drugs. I just don't. Because, I used to make a joke in New York that every so many months, we're going to see a news piece where they found a ship, and they were almost always by the Verrazano Bridge, and we found all these drugs. It was almost scripted. So I don't want to get into conspiracies, but I appreciate the question, because I ask anyone to look at the system, and maybe my plumbing example is a good one, to look at it from that place and say, I love the question of root cause. I love that, because we can't deal with things at the surface, right? In order for me to heal, and I've had issues in my life, I had to identify what happened to me. Why did I do things in my life? And it was a way of managing pain. It was a way of me feeling good about things in a very unhealthy way. So it's something we can talk about for hours, but I appreciate the question.
We could. Well, thank you. I appreciate that too. And, I'll just one comment and then I'll be quiet. Your comment, like the Black and brown and poor whites, there are wealthy whites that women are addicted to opioids. So to me, this is across the whole board. One person, no matter who it is or where they come from, needs to be saved. And so thank you.
Totally agree.
Thank you. Next is Jeff Quam with the Connecticut Certification Board.
Jeff, great man. Hi, Jeff.
You're muted.
Good afternoon, Sam. Good to see you again. One question, and it may be rhetorical, so forgive me if it comes out that way, but if the president revokes the crack house statute and makes funding on the federal and state level eligible? Certainly for the rural areas, the USDA has some funds that they use, but does that not invite the need for some external oversight? There's always external oversight with governmental dollars, and so it's a double-edged sword. Is that something that you're expecting as we move forward?
Yeah, no, I think it's an important question. It's something we worry about. I'll be honest about it. I am confident from many of the meetings we've had, the communications we've had. This recent response by Rahul Gupta absolutely, one of the things I said to the harm reduction community, to the treatment community, to folks who believe in our work, when people were celebrating the fact that they said harm reduction, the president said harm reduction in his State of the Union. That was nice, but we shouldn't dance in the street and celebrate. It wasn't enough. And that's one of the dangers that we participate in, where we celebrate something when it's not enough. And so I told people, please stop it. Let's stop celebrating the words harm reduction. That would have been great 10 years ago, 15 years ago, 20 years ago. We need to talk about the facts. The things you guys are talking about here are just blowing my mind. I want to share this with everyone. You're holding your own feet to the fire. You're talking about the fact that we have a fentanyl crisis and people are dying, and they don't have to die. So yes, I'm worried, Jeff. And at the same time, I will turn my advocacy hat around when that happens. So I'm willing to take that risk in that way. I don't expect a ton of regulations. I really don't. And I hope I'm right. I hope I'm right. And so it's important that in order to operate, we do need that to change. And I think similar to other services that are like ours, the government themselves may not create the regulations. If the states and the cities and those jurisdictions create the regulations, I feel a lot better. We don't need the government from way out there telling us what's appropriate in our communities, right? We do need a standard that's kind of out here and then allow us to do what we're doing. The blessing I've heard from many legislators is the fact that we open and now we have some stuff and people. So when we create, and I say we, because I want to be at the table. If you're not at the table, you're likely on the menu. So I want to be at the table, right? When we create these regulations, it's to say, don't change what's working. Don't change it. If we need to add some things legally, of course, all those things, we have to be careful. If medical providers are involved, I know we have to be careful. I wouldn't want any medical provider to lose their license. But at the same time, the blessing today is we're not starting regulations based on other countries. We're starting regulations based on success in our country. And that's pretty exciting for me.
Great. Thank you. I look forward to sharing our conversation early next week.
Thank you so much. I appreciate you so much, Jeff.
Thank you. So I wanted to move the conversation to a little bit different, and I'm so glad that many of the stakeholders are around here. So as I started in my initial part, that 2021 was the deadliest year on record in the state of Connecticut for the unintentional drug overdose. Let that sink in. We have had more deaths than ever in the history of our state in 2021. And unfortunately, 2022 is moving in that direction as well. That's the ground reality. The question comes down to what are the various things that we are going to do. We have been doing a lot of different things in our state, but this is also part of the solution. This works. Data is getting more sound from other parts of the world. This is an effective way of helping prevent deaths and also creating opportunities. Again, we also know that when On Point was initiated, you were leaders at the national level to be able to do what you have done. But I think we have reached a point with your experience and the experience nationally and internationally that there may be a way to have the state be part of the regulatory process but also state and other municipalities create some funding source like a pilot projects to start to see if we can help organizations in this space be able to take a risk with partnership from state and also municipal sources. I think that's what it's going to take to get to the next level. And this is against Sam. You can weigh in too, but I wanted to just make that statement and see how I react if people did not pass out or people clapped or they were happy or. But it's point that time has come that we should probably have some pilot projects in our state, at least 2 or so, and then start to look into what we can do. So yes, no, maybe whatever you want to weigh in, it would be good to, you can raise your hands.
I'll just say quickly, where we are, we're actually working closely with the state because we don't want to pilot because we've been open. What's really good about a pilot is the levels of protection. So I think for a state, any jurisdiction that hasn't opened one yet, a pilot is a good idea because it does create safety and it creates an opportunity to decide what you want the outcomes to look like and get there while the country, while DC is figuring out what they're going to do about the crack-out statute. So I think it's a good idea, but I just wanted to add that.
Thank you. Kevin Alvarez.
Thank you. And I take Sam's comment quite well. I think the only resistance that I'd have to say pitching something as a pilot is the amount of time that it takes from when we say we're going to do a pilot and put a very small amount of money into it, from the time that happens to oftentimes it never becoming sort of fully realized. And so I'd say there is, if we do it in the right way and we do it where we are clearly communicating to the public that this is a fundamental good that will benefit our community, then I think we really need to put our backs into it. And we're in a position now in Connecticut where we have financial resources available to us that we have rarely had before. We have a situation where the role of government in trying to create better services for our residents and take care of them, whether it be trying to reduce homelessness, having more permanent supportive housing, all of those things, there is a public will to really tackle these things. And so I would just say, speaking to legislators here who have this enormous power and opportunity in our next legislative session, it is sometimes easy for us to do a pilot and then not take step 2. I would say, I think pilots are always a good idea to try something out, but I think there's a lot of evidence that shows that this is a good idea. And cities like New Haven are really, really eager to work with the state to try to get to something that's not just a pilot, but a fully realized wraparound medical care services for all of our residents, regardless of what they're struggling with. So just wanted to mention that.
Wow, that's wonderful. Thank you.
Thank you. Representative Terciak.
Thank you very much. Sorry about that. I think our number one problem is it was mentioned earlier, and then we did what we usually do and turned away and didn't pay attention to it. And that's about planning and zoning and about approval for having a site like this. Last year, a couple things happened in planning and zoning that are worth note. The legislature said that we're going to overrule every locality in Connecticut and tell them that they have to allow restaurants to have outside dining. It's no longer something that people have to apply for a permit. At the same time, there was a locality that had denied a group home permission to open. They were willing to fight it for years. And when they lost and had to pay millions, some people said it was worth it. Because while they did that, the group home people went someplace else. That's the kind of resistance we're going to meet. And that's the kind of stuff we have to be able to get around. And I appreciate that. And one of the good things about that is almost everybody providing addiction services has already dealt with that. It's just going to happen again. Thank you very much. I appreciate this discussion.
Thank you. Steven Zuckerman or Dr. Podolsky, if you want to weigh in too about my comments.
Yeah, as far as the ability to be able to do such in a pilot, I think, our organization would certainly be willing and able. Again, I think, as Kevin said, this is an opportune time with all of the monies that are coming into the state, particularly around the settlement. I know that there is a committee being formed that I think Commissioner Navarrete is going to be charged with overseeing. That's going to be working with and speaking around how to spend some of those monies for services and for treatment. I see this as something that could be at the top of the list. Again, we're serving almost 6,000 of these patients a day, all with a multitude of diagnoses, but certainly with opioid dependence. And we certainly have the ability to be able to expand out, at least at our current sites. But like Representative Terciak said, going to a new location would be quite arduous. We're seeing it right now with a suit we've been in Middlesex County. So yeah, I think the pilot is a great idea. We have to figure out that funding piece, and then we could go from there. I'm sure if I present to my board, I'm sure that Dr. Podolsky and I will get some positive feedback.
Yeah, and to just to kind of segue from what Stephen reported, I think it's important when you're doing a pilot to have a partner that has the subject matter expertise to be able to deliver the best treatment and thereby the best outcomes possible. I'm fully confident that our team at the Root Center will be able to do such, in addition to everything that he mentioned about space and possible funding opportunities. So thank you, Dr. Anwar.
And I'll just add, of course, we are available. Actually, one of the things we're doing in LA right now is providing technical assistance to an organization out here. So it's something we're putting a lot of energy into at this time.
Thank you, Sam. We'll take you up on that one as well. And Mr. Jenkins, you had a comment.
And again, with all due respect to the Root Center as well, we are actively working with active using populations on a daily basis and have a site within the inner city and are equipped and ready with, I guess, the blessing of the city to be able to move forward. We already have this cut out and the infrastructure in place, as well as having the opportunity to partner with individuals like the Root Center to be able to make those warm handoffs or what make these types of things possible. But I think it's also very important to look to the individuals and entities who are also already at work doing this work with these populations, active populations. That is very important that they're at the table as well.
Thank you so much. And as we move forward, I think today what we have done is we've initiated an important conversation about the fact that we have opportunities. If the goal is to save lives, which it is, and if it is a goal is to identify ways of being a part of the solution to the individual journeys of our citizens who are going through struggles with substance related issues and also preventing death, but subsequently increasing the probability of them going for a comprehensive long-term solution in their journey. We have to start to look at what are the things that are out there which we can look at. This is clearly an area of opportunity. Our state is, in my opinion, ready for looking at this seriously, because we cannot just say every year that this is the worst year that we have had and then continue to move forward without making a systematic, broad change in how we are doing things. So we will be having more conversations going forward. We will be looking at our areas of opportunity around this. And with that, I'm going to have the closing comments from my esteemed co-chair, Representative Steinberg.
Thank you, everybody who's been involved today in this important conversation. Hope is not a strategy, neither is despair a good way of looking at a problem like this. I'm encouraged by the fact there are a lot of ideas out there, but more importantly, that there are programs that are really working out there. And as I opened, there is conceivably more funding on the table than we've had in the past, but it needs to be directed appropriately, efficiently, and quickly for us to really have an impact. So some of this is not necessarily in the hands of this committee or even the legislature, but we as a committee can certainly inform those who are making those decisions. And I think there's still an opportunity, even if for those of us who are a little preoccupied with getting reelected, to continue this dialogue right through the fall, so that come January, if there are things that the legislature should do beyond simply advocating for the right kind of solutions, that we're ready to go, that we hit the ground running and we bring about the change that is necessary. Any life that we can save is worth it. So I thank again my esteemed co-chair for coming up with this. I'd like to see what we're going to do next week. You know, we're covering a lot of ground here. Thank you.
We stand closed. Thank you.